Hey, what's up? Welcome back to the Less Invasive Podcast, your source for minimally invasive surgery, robotics, and other assistive technologies for the operating room and radiology environment. If you haven't done already, please take 5 minutes to subscribe, rate the podcast 5 stars, maybe write a little review, and share with a friend. That will help this content reach more people. Today, this show is reaching thousands of people in over 40 countries, mostly Europe and North America, but also Middle East, Asia, Latin America, and Africa. I'm your host, Lucien Bordel, co-founder and CTO of Quantum Surgical, a startup commercializing the Ep13 robot for percutaneous tumor ablation. I bring to the table 20 years of experience in imaging and robotics for various specialties: orthopedics, neurosurgery, spine surgery, interventional radiology, and interventional oncology. Today, I'm very excited to have Dr. Vanash Patel on the show. So, Dr. Patel is a board certified general surgeon with a specialist interest in colorectal surgery, practicing in London and Hertfordshire in England. He has been using the Versius robot from British company CMR Surgical for quite some time. Started in July or August last year, and we'll talk about that. So this new robot for soft tissue surgery has been launched in 2019, and today there are over 100 units installed across Europe, but also Asia, Australia, Latin America, and the Middle East. And the specialties in which this robot is used are gynecology, colorectal, thoracic, general, and urology. We'll talk about the Versus robot, feedbacks from early clinical experience, of course, the purchasing process, and more. Vanash, thank you very much for making time for me today. How are you?
Very well, thank you, Lucian, for inviting me on the show. Very happy to be here and talk about Versius and our robotics program at West Herts.
Cool. Yeah, I mean, many people are very eager to listen to this episode. So the audience of this podcast is kind of a mix of medtech industry people and physicians in various specialties, and they want to learn about Versus from a surgeon who has been using this system from more than 6 months now. But before we talk about Versus, can you briefly introduce yourself to the audience?
Yeah, so my name is Vanash Patel. I'm a consultant colorectal surgeon. I trained in London, did fellowships in London teaching hospitals, and eventually got my consultant job at West Hertfordshire Teaching Hospitals NHS Trust. Predominantly, my practice is colorectal cancer, and prior to robotics, I was doing my colorectal cancer resections laparoscopically.
Okay.
In our unit, we achieved a laparoscopic rate of 97% for all our colorectal cancer resections, and now we've translated that 97% laparoscopic rate to hopefully a 97-98% robotics rate in the future. So we've managed to train our entire colorectal unit in robotic surgery, and we're trying to do all our colorectal cancers robotically now.
Okay, cool. Thanks. So you are both an NHS consultant and you also have a private practice. Who are your patients in terms of demographics and pathologies, and what are the most common procedures that you perform either laparoscopically or now in the future robotically?
So most of my procedures that I perform, so if I talk pre-robotics, it was all done laparoscopic. It was colorectal cancer, and some benign conditions such as inflammatory bowel disease, including Crohn's disease, ulcerative colitis, and that was the sort of the elective part of my practice. In terms of emergency part of my practice, then we were doing sort of common general surgical emergencies like appendectomies, Hartmann's resection for diverticular disease, small bowel obstruction. And in my private practice, it's predominantly, still doing colorectal cancer, but also doing general surgical elective operations like hernias and proctology, hemorrhoids, fistulas.
Okay, thanks. So in the previous episode with Arnaud Dua, we talked about conventional laparoscopy and the challenges. So we won't talk about that right now, and we'll jump right into the topic, which is the Versus robot. For those who may not know what is Versus, what Versus does look like, and what does it do exactly?
So Versius is a robot that's it's manufactured by CMR Surgical. It's manufactured in Cambridge, which is quite local to us. West Hertfordshire Hospital's teaching NHS trust is in Watford, and Cambridge is only about 50 or 60 miles away. So we call that local, and it's nice to have a local company that provides our robot for us. It's a modular system, so it has a console with a high definition 3D screen with the control arms, which essentially look like PlayStation controllers with joysticks. These control four bedside units. So three of the bedside units have instrument arms that can be used for instruments, and one is a visualization bedside unit, which is used for the camera. And essentially what you do is you put in your traditional laparoscopic ports in the places that are more aligned to the robotic surgery, and use the same ports that you're using for your laparoscopic surgery. And then you dock the robotic arms next to the patient's bedside, and put in your instruments through the ports. You port train them through the ports, and you put the camera in as well, and then it's ready to go. And then you sit or stand on the console, and begin your operation.
Okay, so I jump to the question. You mentioned that pretty much you place your ports the same way you would do for a conventional laparoscopy procedure. There is no constraint on
So,
port placement.
there is. So it's not exactly the same place as
Okay.
your laparoscopic surgery. We use the same ports, so we don't have to use specialized ports that are developed by the company. We just still use
Okay.
our ports that we bought from other companies. The port placement is very similar, and actually, the more experienced you get with the robot, I found the port placement is not as important as I thought it was in my early stages of learning. So as I've got more experience and got through my learning curve, the port placement for me now is not too much of an issue, because I'm using more wristed movements rather than straight sticks for operating. So so I would say it's pretty much very similar to your laparoscopic operation. So I haven't had to change much of how I operate. It's just now I'm sitting down on a console using a three-dimensional screen, and it's much more ergonomically better for me.
Okay, and talking about ergonomics, I just watched a live event from Arab Health trade show where someone from Robotic Surgical Systems, a company that is distributing the CMR robot in Middle East, they demonstrated the product, and they've shown how the console can work. Either with the surgeon sitting on a chair or standing up. So my question is, did you try to operate standing up with the console, and what has been your feedback?
So actually, I've not actually tried operating standing up, because I prefer sitting down. My colleague, I was actually assisting my colleague this morning in theatre, and he was trying to stand up and operate, and he found that quite comfortable as well. So personally, for me, I'd prefer to sit down, but I think I might try it in the future. I don't know. It's not. I've been standing up for all these years, and actually now I've got the opportunity to sit down and operate. So I thought I'd take that opportunity.
Okay, okay, I see, I understand. So I have a question from another general surgeon from Texas, Dr. Jawad Ali, who was in a previous episode, and he was saying that I mean, the Da Vinci technology is a great technology, of course, but the console is can be when you do a very long procedure, it can get uncomfortable with sitting in the Da Vinci console. Have you
Mhm.
had a long procedure so far in your experience with the Versus, and how comfortable is that?
Yeah, so a lot of my operations are fairly long, because we do sort of rectal cancer work. I think it's different to the intuitive Da Vinci, because it's an open platform, so you don't feel so constrained and immersed within the robot. But I've not felt that fatigue looking at the screen. I mean, initially in my learning curve, yes, there's a lot of fatigue when you're learning, but now I find it's fine. You're just sitting there, and you can talk to your colleagues, and your colleagues can sit next to you, and you can talk to your theatre teams. So it's fairly dynamic and fluid. And um, if you're feeling tired, and you want to get your eyes off the screen, you just stand up, go into the coffee room, and have a coffee, and come back. So that open platform really works for me. I know Da Vinci surgeons, that they also look at the Da Vinci and say they actually feel more immersed in the operation, when they're using the periscope or the Da Vinci. So advantage and disadvantage of both
Mhm.
systems. So
Okay, I get it. I mean, this topic of open console was raised also by another surgeon on this podcast, a surgeon doing pelvic reconstructive surgery, and she mentioned that communication with the team could be quite a challenge. To make herself understood about where she want the scope to be and where are the instruments and I think that the open console and the smaller form factor of the Versus should improve the communication. That's something you started to talk about. How is this has been working for you? How you communicate with your staff during the procedure?
So communication's fairly easy with the open platform because you're the console sitting in the theatre and you can just talk to your theatre scrub team or your assistant, your surgical assistant. So and you can speak to the anaesthetist. And in fact, in actual fact, my anaesthetist sits next to me with the anaesthetic machine is next to the console. So communication is not difficult. What is challenging is that when you start your robotics program, you have a lot of people in your theatre, and it can be quite noisy. So communication can be affected that way. But as robotics has become more of a normality in our hospital, less and less people come to theatre, and actually you find that communication is much better and much clearer with the open platform.
Okay, so I understand you haven't been trained before on the Da Vinci system, correct?
No, so I've had some experience during my training, as a surgical assistant with the Da Vinci system, but I've not been formally trained on the Da Vinci system. So essentially, I would say I'm robotic naive
Mhm.
from when I started in July.
Okay, interesting. So another question about the ergonomics that the one of the 3D screen, 3D glasses. I mean, there is a third a system from Medtronic, the Hugo robot that have
Mhm.
3D goggles, and there can be some concern, some question about how comfortable is it to have this kind of new way to get 3D vision. Did you experience any trouble with the glasses with a long procedure or?
Uh, no. I thought, how am I going to wear 3D glasses through a 4 or 5 hour operation? But actually, you don't actually notice you're wearing the glasses, and because you get such good um, your vision is so much better than traditional laparoscopic surgery. You actually don't mind wearing the glasses, and getting the 3D vision. So I've not found it's prohibitive wearing the 3D glasses. And some of my colleagues have gone out and bought their own sort of 3D glasses which are more bespoke to them, and I just use the generic ones. But it's fairly flexible like that. You don't have to use the 3D glasses that are provided by the robotics company. That they're sort of standard 3D glasses that you can buy from Amazon or any other sort of shop that you want. So I haven't found that an issue at all.
Okay, interesting. I think, and now it's more a technical question because I'm kind of a CTO of a company, so I'm looking at the technical details of the product and the joystick that you use to control the three instruments and the scope. Like in the Da Vinci, you put your finger and your thumb into a kind of a jaws and you operate like that.
Hmm.
It seems like with the Versus, it's kind of a different approach with the joystick. You have more button, maybe no foot switch. It's a little bit different in controlling the instruments.
Yeah, so it's all hand controls. So it is very much like if you had a PlayStation controller and split it in half, one hand goes in the left hand and the other hand goes in the right hand. So it's got a joystick, it's got the finger graspers to open and close the jaws. Your hands and are moved on the actual arms, and then it's got some buttons for the diathermy and coagulation. And actually, with the sort of virtual training that you do on the console, you develop muscle memory quite quickly, and when you're doing the operation, you know where all the buttons are, and I can flick between all three different instruments and flick them between different hands very quickly now. It's actually very easy to use, I would say.
Okay. So it's kind of like a PlayStation. I will come back to the topic of the training, but before that. One of the benefit of a soft tissue surgical robot is scaling the movement. Can you explain for someone who doesn't know this kind of robot, how does it work, the scaling of the instrument? Do you have to choose the scaling ratio, or how does it work?
Yeah, so there's different scaling ratios. So depending on how quickly you move your hand and how quickly it moves inside. I've not changed too much of the scaling. I used the sort of the middle of the ground scaling options for what I do in my operating. But yeah, you can use different scales. So you can move. A small hand movement can move the instrument faster and in a bigger stroke inside the abdominal cavity. But for me, I don't change scaling too much.
Okay, so the default setting is fine for you, right? So,
Yeah, the default setting, and I think my colleagues use the default setting, and I don't think people change it very much.
okay, it's more like an engineering feature for engineers.
Probably,
Okay,
yeah.
okay. So when it comes to such kind of a big, I would say big capital equipment, but also the Versius robot is on a modular and smaller form factor than the existing platform on the market. There are always some question about the setup, the layout. Can you share your experience? You've done probably dozens of cases with the system in various
Yeah.
procedures. How does the setup work, and are there any specific constraints on placing the bedside units? What's your feedback on that?
So one of the reasons we got the Versius system is because our operating theatres are in two different blocks,
Okay.
and actually we transport the robot between these two different blocks, and it goes down a lift, across a corridor, up a lift.
Okay.
So today, one of our systems is being used in one block, and the other system has been transported to the other block to do some gynae procedures. So it's quite versatile like that, and it's very easy to move. We actually store a lot of our equipment in a cupboard. So essentially, if I'm operating tomorrow, the nursing staff will wheel the bedside units out of the cupboard. They'll wheel them into theatre. They will arrange them around the bedside. They'll plug all the cables in, and they'll plug it into the console. They'll drape all the arms, and then we'll sort of brief about the patient. Patient will be put to sleep. Patient will be brought into the anaesthetic rooms. I will put my ports in, and then dock the arms next to the patient, and then the operation begins. So that whole process doesn't, it seems like it would take a long time, but actually, from me putting the laparoscopic ports in and docking the arms now, it's down to about 7, 8, 9, 10 minutes. So that's quite a quick docking process, and doesn't add much time to the operation at all.
Okay, understood. And I understood also that this system brings some kind of a flexibility in terms of planning either a fully robotic procedure or integrate a laparoscopic instrument for specific portions of the procedure. How does it work? Is it something that you
Yeah,
you, you experienced?
yeah. So initially, during your learning curve, sometimes you might not want to do the whole operation robotically, and do part. We used to break up parts of the operation and do parts of the operation laparoscopically and parts of the operation robotically, and that's just, the system allows you to do that because you can undock and dock the arms quite quickly. So for example, if I so now I try and do most of the operation robotically, but if I'm doing multi-quadrant operations, which I often do for my rectal cancer work, I would dock the robot in one way to do one part of the operation, then take out all the instruments and arms and reposition the robot to do another quadrant in the pelvis. We could actually reposition the arms 3 times during an operation to get the optimal performance of the robot and make the operation smoother and easier. Because you can take the instruments and take the arms on and off quite quickly, it's quite quick to change your quadrants and do multi-quadrant surgery with this system.
Okay, understood. And another technical question. So there are these fancy LEDs lighting on each arm.
Mm-hmm.
What's the information that is conveyed through this lighting,
So
and do
so
you use
yeah
it?
so the lighting is quite key because each arm has its own color,
Okay.
which then corresponds to your console, and it tells you which instrument, because it's color coded.
Mhm.
So if my fenestrated grasper is on a pink, it comes up as a pink icon. It will be the pink arm with the pink light that it's controlling. So I can, because it's an open platform, I can look at the console and then look at the arm as well, and make sure there's no clashing and the arms are not getting close to each other. So it helps with communication in terms of which arm is being controlled by which icon on the console.
Okay, understood. And about the introducing a robot into a hospital, people look at the cost and recurring cost. Can you talk about the disposables? What kind of disposables comes with the Versus system, and how do you reprocess this equipment?
So the actual disposables, there's a range of instruments. There's fenestrated graspers. There's a hook which uses diathermy. There's bipolar scissors, bipolar Marylands, and needle holders for suturing. All these instruments can be quite easily manually taken off the robotic arm and put into the sterilisation unit. They go through our normal sterilisation process, so we haven't had to change any of our sterilisation process. Our sterilisation process outsourced to another company outside the hospital, so everything gets packaged up in a tray and gets sent to the sterilisation company, and then it comes back to the hospital all clean. The actual robot tells you how many uses you have on the instrument, so it will flag up if a particular instrument is losing its life, and then you would bin it. So it's fairly clever like that. But in terms of sterilisation, it's we haven't had to introduce anything new, which has been easier to implement this sort of thing without having to have lots of new things going on in the hospital.
Okay, understood. So we talked a lot about the technical side. Now moving on to the clinical. Let's start with the basics. What's the training like? So I've read that there is kind of a 7-step process, which can seem a bit long, but that leverage different kind of technologies like e-learning, virtual reality, simulation, maybe also preceptors. Can you walk us through these training steps that obviously you went through yourself?
Yeah, so I mean, I could take you back. So we bought the robots in April last year. They arrived in the hospital, and then we had 3 months to organise ourselves to work out who which teams are going to go up for training, when they're going to go for training, when we could do our first clinical cases. We then had to do virtual training. So with the console comes almost like a PlayStation box, which has tasks on it. Sort of cutting circles out with the instruments and doing suturing anastomosis and different. There's about 10 or 12 different tasks, and it actually measures your performance. So when I did the training, you'd have to do 6 hours on the virtual trainer. It doesn't have to be all together. So you would, if you were having a break in between your theatre cases, you'd go and sit on the console for an hour and do your virtual training. It's now moved to a metrics-based system, so the better you are, and the better you meet your targets, then the shorter your virtual training is. So once you've done that, you do some online training modules looking around the safety of the robots and different aspects of that. And then we went on a cadaveric course. We went to ERCAD in France, Strasbourg, and that was a team's training. So 2 surgeons and 2 nursing staff went out as one team, and we learned how to set up the robot, drape the robot, and then we had practice on cadavers to do specific operations. For me, it was right hemicolectomy, low anterior section, and then the week, so we finished our training on the Thursday, and the following Monday we did our first clinical cases, and that was a dry run in the morning. So that would be the whole team would be there to set the robot up to see how it would fit in the operating theatre, and then in the afternoon we did our first clinical case. And with our first clinical case, there was a preceptor, so someone who's already used the CMR system, who's got past their learning curve, and they were there really for support. They're not there to tell you how to do the operation, but they're there to teach you how to use the robot and iron out any sort of difficulties you may be having. And it was just nice to have someone that's used the system there to help out. We did 5 precepted cases, and then after that, I moved on to doing operations by myself with my consultant colleague who was also training with me. And for our first few cases, we did dual consultant operating to make sure it was safe. And then once we felt we were in a position where we could operate, by ourselves, then we would then do robotic operations by ourselves as individual consultants.
Okay, understood. And so you mentioned the learning curve. So you've been using the robot for 6 months, and so it's many surgeons have been also trained on the system. How long is the learning curve typically for this kind of robot?
So we so in our business case, we said that the learning curve would be around 20 cases as a sort of estimate. In fact, I found that it was fairly easy to use, and our learning curve in terms of measuring it in terms of theatre utilizations are getting back to our normal number of cases per list. We were not back to our normal theatre utilization after 10 days, 10 cases, which was a huge achievement for us because it meant that we could do our 2 colorectal cancer resections on each list. So that was a really positive thing from the learning curve. I think it helped because I had another consultant operating with me, and we were doing dual consultant, and that helped with the training process. It helped that we had a lot of support from the company, so we always had an implementation lead and an engineer with us, which meant that the operations went, the robotic systems working smoothly and not having too much difficulty, meaning that we could actually perform the robotic case rather than the robotic equipment breaking down and not being able to do the robotic case. And in terms of case selection, so initially for our first 2 or 3 cases, we did try and select the sort of easier cases that, not sort of high BMIs and the sort of easier operations like right hemicolectomies. But then after 3 or 4 cases, I said, well, I can't really keep selecting cases because those are not the cases that are coming through the clinics, and we just have to operate on whoever actually needs an operation. And what we did was, rather than do case selection, we would do select parts of the case to do robotically, and perhaps for when you're doing colorectal cancer resections, we could split it up into its modular parts and maybe do two parts out of the 3 robotically and finish off laparoscopically. And that way we managed to build up quite quickly in terms of our learning curve.
Okay, very interesting. This capability to switch from robotics to conventional and to split the procedure in several parts. So I have maybe a naive question, but how many procedures have you done so far, and have you seen any clinical results, or is it too early to tell what are the benefits of the robot?
So we're running a multi-specialty robotics program. So it's a colorectal, urology, gynecology, and upper gastrointestinal surgery. So we're going to reach 100 robotic cases this week,
Okay, congrats.
which is a really a big achievement for the trust. Within 6 to 7 months. I haven't actually counted how many cases I've done, but I think it's over 30 now, and these are big colorectal cancer resections. So, the robots are in use. One robot's in use 5 days a week, and one robot's in use 2 or 3 times a week at the moment. As more and more surgeons get trained, we hopefully will see that the robots being utilised, 5 days a week for both systems.
Okay, so I have another question from a surgeon who was wondering that does the use of this robot brought something to your practice that you did not anticipate? Because I guess you prepared a lot the introduction of this robot into your practice, expecting some benefits. Are there things that you got with the robot that you were not thinking about before?
Yeah, so in terms of clinical outcomes, we haven't analysed our data fully yet because we don't have the volume of cases to have some meaningful data. But what we are definitely seeing less pain in our patients, particularly around the port sites.
Okay.
And I think that's because the virtual pivot point, and it's not causing much stress on the abdomen. I'm seeing faster gut resolution. So for our colorectal cancer patients, their gut is functioning quicker. Definitely less blood loss, than traditional laparoscopic surgery. When we're actually doing the operation, the planes are not as bloodied as it can get with laparoscopic surgery. I think one of the main benefits I've seen is the high BMI patient. It's a high body mass index patient. I've a few weeks ago I did a high body mass index. I think she had a BMI of 46 for a cancer, and it's a patient that I don't think I would have been able to operate laparoscopically very well, and may not have been able to complete the operation laparoscopically, but robotically, I managed to do the operation robotically, and it wasn't that stressful. And the patient did very well, went home on day 3, and that's something that I've seen, that the high body mass index patients, and I've done a few now, the robotic system is much more capable than straight stick laparoscopic surgery. So that's one thing that I think is much better for me. It was, having a patient with high body mass index it's not very nice to operate, because it's quite difficult and challenging. But now I don't actually see that as a problem anymore. I find that actually it's okay to operate with a robot.
Okay, so I understand you are building your clinical data right now, and what you've seen is that it facilitates the most complex procedures, for instance, with high BMI patients. So talking about the data, CMR Surgical is talking about a registry for this Versius robot. For someone like me who
Mm-hmm.
is not on the clinical side, could you explain what is this registry and how it works?
So essentially, the registry captures all the data from the robot. So from docking time, using the robot, ergonomics, how the surgeon's using it, and it all gets sent through the internet down to sort of servers and get stored, and that data can be analysed and used. And essentially, it will, that huge amount of data is probably what is the most important thing about robotics, because that data can tell you, or will eventually, I think, be used in the long term to try and almost improve autonomy of a robot, and looking at where errors have occurred, and can we reduce our errors when we're during an operation. So I suspect in several years' time, when the data and when we've got lots and lots of data and it's all being analysed, the robot will be able to tell us not to cut this vessel, or there is a potential that there's going to be bleeding here, so be aware, and things like that. So that's the power of the data that's being captured.
Okay, I understand. So it's preparing the future and more intelligence into the surgical robots that will leverage
Yeah.
this data from coming from various hospitals. So you mentioned that you've been using the robot for maybe 6-7 months now. So I mean the initial goal of this phase was to learn and get accustomed, you and the team, with the robot, and being able to move to your normal practice and doing all robotically. So what's your goal in 2023 and the year forward with the Versus robot? What's the next goal with robot?
So I think we want to increase the number of robotic operations that are being offered across all specialties. We've trained 10 consultant surgeons so far, and we're going to be sending another 3 surgeons in the very near future. So to expand the number of people that are going to be using the robot. We've trained 2 upper gastrointestinal surgeons, and they're starting doing their robotic. So upper gastrointestinal surgery traditionally hasn't had much robotics experience. So that's something that we're planning to improve and do operations there. I think I'd like to expand it to day surgery cases. So our sort of hernias,
Yeah.
gallbladder operations, and put it into our day surgery unit and see if that can be doing high volume day surgery cases, which I think is doable with this sort of platform. And potentially branch out into emergency surgery. So emergency surgery is the tricky one, because we don't know what surgeries are going to be coming through the emergency rooms, but definitely we would want to try and see if we can utilize the robot doing emergency surgeries.
Okay, so expand to new procedures, going to high volume inpatient procedures, and next going forward. So Maybe one last question about the Versus. How does the cost compare to a conventional platform that is commercially available? Is it a lower cost competitive advantage that is offered by CMR Surgical today?
So look, I think all robots have their advantages, disadvantages. I wouldn't say one robot is better than the other robot, and you have to see what's being offered by each platform, and each platform has different offerings. I think with CMR Versius, it's a modular system. It's easy to move. It's flexible. You could probably do more. You could probably do more multi-quadrant operations at higher volume. And it's lower cost. So we have to talk about value-based healthcare. Not everyone can afford a really expensive robot that has all the sort of complex devices like staplers and things like that. So you've got to think, how can you bring robotics to the mass population? And we live in a constrained society with cost of living crisis at the moment. So this sort of platform can develop robotics in centres like ours. It doesn't have things like the energy device or staplers or
Yeah,
clippers,
yeah.
which other platforms already have. Does that mean it will never have it? I don't think so. I think the company is very it develops its equipment very quickly, and it listens to its stakeholders and feedback. I think those sorts of instruments will come on stream, at some point in the future, and probably very shortly. So we would have to see, where does this robot sit in 1 or 2 years' time with the extra instrumentation that it may have. But yeah, I think there's advantages, disadvantages of both, and my gut feeling tells me that if you're in a robotics center, I think it's going to be multi-platform use. I don't think you can either say you can only use this robot or
Mhm.
this robot. I think you're going to need a variety of robots to make sure that your center is a center of robotic excellence. So, we might need a CMR system, we might need another system from another competitor. I think there'll be a variety of robots to use for different types of operations and different settings.